they have any tape allergies. Some patients have an allergic reaction to tape, and you have to use this paper tape. The problem with the paper tape is that it's not as sticky. You know, it doesn't last as long. Okay, so we've got this all ready to go just in case we've got to give them some more contrast. We have to be aware of the arm. Also, it's a good idea to have, excuse me, I lost my slide. A washcloth and an emesis basin close by, because once you give them the contrast, they're going to feel hot and they may start to feel nauseous. So I usually just leave it up here. I can get a cool cloth, get it wet, put it over their head. Maybe that'll be enough to get them to cool down and they don't actually start to throw up. But you want to have the emesis basin. I wouldn't put it somewhere where they can see it, because then you have that power suggestion. Just like saying, do you want to throw up? I wouldn't say with that. I'd say, like, how are you feeling? How are you feeling? You know, that whole power suggestion thing. So I'm going to have everything kind of up here where the patient really can't see it. Also, we want to have some kind of support under their legs because they're going to be on the table for probably at least 30 minutes. Okay, watch out. I'm going to move the table around a little bit. Okay, so how are you feeling? Okay? Sometimes they'll start to say, like, oh, I have this funny taste in my mouth, like aluminum paper. Yeah, metallic. And that's just how the iodine makes them feel. Yeah, actually, when you get contrast, what it feels like, have you had it, or is just you're saying that from what patients have told you?
From what patients?
When you've had contrast, my analogy would be like, you know, when you're standing on the edge of a cliff looking over, and you get that weird, like, jumpy feeling in your stomach and kind of hot all over. That's what it feels like when you get contrast injected. It only lasts a few minutes, but okay. So I need not only my markers, but I need my time markers. For some reason, we don't have a 0 over here anymore. Yeah. You see, a lot of our markers have seemed to have disappeared. I just don't know where they've all gone, but okay, so as soon as the contrast is injected, because I've already done my scout, I don't need to show you how to do it again, right? I'm going to mark the film with the right marker here at the bottom, and then the 1 minute. My first film is going to be 1 minute. So I have a 1 minute marker here, okay, or here, just on the very edge of the cassette. Cone down to 11 by 14. On your smaller patients, you can cone down to 10 by 12. Because what I don't want to see is I don't want to see light all the way out to the side here. You should cone down just to the edges of the ribs. So the light's going to be at the iliac crest.
So that would be crosswise if you cone down?
Yes, always crosswise because we're getting 2 kidneys this way. The top of the light's around the axilla, the bottom of the light's around the iliac crest, right at the MSP, because we've got 1 kidney here and 1 kidney here, right? Okay, so this is our 1 minute. It's above the xiphoid process, 2 inches, just like you do an upper abdomen film, or bilateral below the diaphragm film. This is all the same, okay? So that's a 1 minute. Change my film out. Now I'm going to do what's next after 1 minute. 5 minutes.
5 minutes.
Nothing changes. I want to make sure my patient didn't move, because sometimes they'll move around in between. Okay, now what's next? 10 minutes? 10 minutes. What
10 minutes.
do I need?
10 by 17.
So for IVPs, you're basically dealing with 10 by 12s or 11 by 14s for the upper, and then 14 by 17. And where am I going to center?
At the iliac crest.
Iliac shield? Iliac crest. Just be careful with the gonad shield. I would shield males, but I would be careful. Don't have it up like this, because then you're going to cover up the bladder. Just have it, just at the gonads. Okay, so MSP and iliac crest, just like all your other KUBs. So I've taken the 10 minute. Now what's next?
Like
Sponge. So change out my cassette. Remember, you're going to use the smaller side of the sponge for the 30 degrees. And don't put it so far under the patient. Don't put it all the way against their spine. Only have them roll up partially. So come towards me. Be careful of his arm. Roll back. see, that's 30 degrees. This is 45 here. This is 30. See the difference? So you're putting the sponge like right at their side, not all the way into their back. Okay, the key to this is you want to make sure that this line here is always at the MCP. MCP. The outer line is going to be at the MCP no matter how big your patient is. Where'd your tummy go, John?
I don't know.
You lost your tummy.
It's supposed to be over there.
Here, I'll give you. Okay, so.
Not everybody flat wash.
See how we've got abdominal girth going this way? We want to make sure that the light is at the MCP here. Let me roll you up just a little bit here. Okay. Because remember, the kidneys are going to stay by this spine. They're posterior. So this is like the, 3 fingers in from the ASIS. See how that works? This is absolutely number one will help you in your positioning on the legs. But you don't have really hypersthenic patients in this group, or students, but in this morning, everybody's like all the hypersthenic people are in the morning group. But it doesn't really matter. For this, you just want to make sure that your light is going to be right at the edge of the MCP. Don't worry that you don't see the side of the abdomen over here. Because what happens, the mistake people often make is they center to the abdomen like this. And what happens is you clip off this kidney by doing that. So if you notice the light stays at the MCP, you're always going to have both kidneys centered to your cassette. Okay? All right, so let's do the other side. And so your card's going to say, oblique for right kidney perpendicular. So what position is that?
LPO.
Left kidney perpendicular would be?
LPO.
LPO. Perpendicular, parallel. Upside is parallel. Okay? So there's 4 scenarios. There's a perpendicular and a parallel, and there's a right and a left. Just like there was 8 on the VE. Remember? So, because I'm not going to put perpendicular right kidney, parallel left kidney. It's the same thing. So make sure you study that. Okay? I know it's not that hard at the hospital. All you have to do is do LPO and RPO, but this helps you in the long run. It really does. Okay, so still iliac crest and MCP. Don't worry about the abdomen. But like I said, if you have an extremely small patient, then you should collimate in. I don't want to see light like this. If you have somebody TAM size, you want to do collimate into the side of the body.
Manny.
Okay, so we've done LPO, RPO. What's next?
15 minutes.
15 minutes. Go ahead and roll it for me. How you doing? You feel okay? Okay, we're about halfway done with your test. You're doing real good. I'll take this needle out in a few minutes. You have a burning here?
Extravasation.
Oh, we better check that. If he's got burning, it could be because he's got swelling. Actually, this morning, this little cap came off, and I was going to just take this here. I'm like, oh my God, the needle's like, what? Wait a minute, got to put the cap back on. Okay, so now we're going to do the 15 minutes, switch out our film. We're going to label it 15 minutes. So part of the challenge for you in the simulated is to use the correct markers. And we'll have to see about why we don't have a 10-minute on this side. Maybe we'll make up some markers.
There's no numbers on the other side. No, just use a piece of paper that.
Yeah. And that's what I used to have. I used to have pieces of papers that I had actually put tape on and laminated it, but everything's disappeared. So what? I bet you they're probably in a box around here somewhere. Okay, so 15 minutes. All right, now I've taken the films to the doctor, and he's like, well, the bladder's not quite full yet, so wait another 10 minutes and take just a cone-down bladder for me. Okay, because we want to see a full bladder. So what size cassette am I going to need for that? 10 by 12. 10 by 12. Thank you. 10 by 12 crosswise. Marker up, marker down. Blocker up, blocker down. It doesn't really matter because the bladder's going to be in the center. No, well, in this case, yeah, because we're still waiting for the bladder to fill, so it would have to be after 15.
So there's a cone-down bladder.
A cone-down bladder. So I'm like, okay, I'm going to do a cone-down bladder. So your card could say cone-down bladder 20 minutes or 30-minute film. I'm going to collimate to...
And that's at the ACES and the MSK?
Well, it's actually...
ACES to ACES.
The top of the light is right above the ASIS, and the bottom of the light is at the symphysis. So you're like 1 inch below the ASIS.
Okay.
Okay. Because here's this ASIS, and I want to include the symphysis up to make sure I got this entire bladder on here. So here's this ASIS, so I'm like 1 inch below the ASIS for the AP. Okay. Okay, so now his bladder's full. So you feel like you need to go to the restroom? Good. So I'm going to go ahead and take this needle off of you. And we have one more film to take when you're done. We'll dispose of this in the red container. Okay. Oh, I'm sorry. I can't let you go to the bathroom yet. The doctor wants one more picture.
Okay.
We see the film and it's still delayed. So they want, because he's got hydronephrosis and we've got a delay, what am I going to do to help move the contrast along? Turn him over. Turn him prone.
Turn prone.
So the prone KUB is just like the prone KUB you did for what study in this series? Small bowel. So where do we center? Which is on what area? Well, not the hump, but the curve.
The curve.
Small of the back, right? Okay. Before the hump.
My hump. Your hump. Your hump. Your hump. Your hump.
So, see, it's right where the small of the back curves, and you can feel the celiac crest right here. Okay? So now we've done a prone. I'll mark this probably 30 minutes. By now, you have to look at your watch and see actually how long. It could be 45 minutes by the time you get the doctor to ask you to do another film. It could be 30 minutes. Okay, what do I need to change on my cassette?
Marker down. 14 by 17.
Marker
Down.
and I'm going to use the left.
Left.
Because now he's flipped.
Yep.
Okay?
And this centering is at the iliac?
Iliac crest and
MSP.
MSP.
14 by 17 like this.
Yes. Okay, now can I send him to the bathroom?
Check with the doctor.
Yeah. Check with the doctor.
I think,
No, I have to put them turn around first.
well, no, sometimes they'll take it prone. Because now it fills up the middle ureters that we haven't seen with contrast. Okay, now go ahead and turn on your back.
Yeah. So now you guys gonna go to the bladder.
And now it's going to go down into the bladder. Okay, before I think I'll do his post-weight and then we'll go into cystogram. Okay, so he's gotten up, gone to the bathroom, he comes back. How do you feel?
Yeah, pretty good.
Okay, well pretty soon you'll get to go and have some breakfast, so I'm sure that sounds good.
Steak.
So now I'm going to use my right marker and a post-void marker and do a KUB. And then for the IVP purposes, we're done. So what I want to show you next is the cystogram. Okay, and then I'm going to do the voiding cystogram, which is upright, and also other films that we may be required to do upright. Okay? So I've showed you the AP cystogram already. So what other two positions are usually required?
Oblique arrow.
Both obliques.
Both
Start.
legs.
So how much do I oblique the patient?
45.
And when I oblique them to the right, what am I demonstrating? The left UVJ.
UVJ. Right. Left UVJ. Okay.
So now see he's up higher because he's at a 45 degree. 10 by 12 crosswise.
So this is part of the system memory?
Yes. He's done
System.
now. The new patient. Got him gone, and now we got another patient we're doing
Yeah.
cystogram on.
Both name job.
Okay, so the trick for centering for cystograms for the bladder, put your thumbs on the ASIS and make sure you're centered to your thumbs are at the edges of the lights of your collimation. So here's his ASIS, here's his ASIS. Okay. Again, the bladder's going to stay in the central part of the pelvis. It's not going to move according to the size of the abdomen like it does with the GI tract. Okay? So we're basically centering 1 inch below the ASIS and then right on the sides, the light's going to be right on the sides of the ASIS. Okay? So we see the left UVJ. Now we're going to do the right UVJ by doing the LPO. Okay, so again, I want to move him over so the light is just skimming the ASISs. So when you look at his MSP, it just goes about an inch laterally to the MSP. But that's going to change. If you have a larger abdomen, it's going to look different. Just make sure you can feel the light's right inside, the edge of the light is right inside the ASIS, and you should have the bladder right there in the center, okay?
For hyperstenic, can you still use a 10 by 12?
Yeah. Your challenge is getting it centered correctly, because the bladder doesn't move like it will. The stomach changes in a hypersthenic, it won't with the bladder. Okay, if he's a male and we're going to look for BPH, what's an additional projection we may have to do? Lateral. Exactly. So I'm going to have you go ahead and turn up on your left side.
Will the card say something about...
What does the card say, Erica?
Card says histogram lateral for BPH.
Yeah. So you may pick that card and get a female patient. You still have to know how to center film out. Okay, so go ahead and bring your shoulders back a little bit. All right, so now I'm going to center. Let me straighten him out.
Should we stop though and ask you, it's female patient?
Okay, so I'm basically using the hand position like I did for the L5S1. My index finger's on his ASIS, my thumb's at his iliac crest MCP, but where I'm actually going to center is my second finger, because I'm going to go 1 to 2 inches below the ASIS, and the back of the light is just beyond the MCP. Because we don't need to see the spine, we're seeing the organs that are going to fall forward. In hypersthenic patients, they're going to have more abdomen, but the bladder's still going to be in the pelvis. It's not going to fall forward like the colon does. Follow what I'm saying?
Yes.
So it's basically, you can use the same hand position, ASIS, index finger, thumb on the iliac crest, but then I'm going down and using this as my guide for the centering. So between here and here is about 2 inches below the ASIS? And that ends up usually being right on top of the greater trochanter. Yes. Or really the acetabulum. Okay. So, which is right above the greater trochanter. But you'll see when you look at lateral bladder films, you'll see the acetabulum and the bladder's right next to it. Okay? But we want to see the superior surface of the bladder too, so we're not going to center too low.
We just opened it all the way.
Yeah, as much as 10 by 12, not 14 by 17.
10 by
10 by 12.
10 by 12 crosswise.
Yes.
You said 1 inch anterior to the MCP?
Do you think that's 1 inch? Maybe more like 2 inches, huh?
2 inches.
Yeah. What I use as a guide is the back of the light here. I don't really go by this centering here. I go by where my light stops here. Okay?
2 inches.
Well, I guess you could call that 2 inches from here to here. But, again, you want to look at your light guide and make sure it's just behind the MCP. Because think about the films, when you review your films, the lateral shows just a little bit of sacrum and coccyx, right? So we're not centering back like we did the sacrum and coccyx. We're concerned about the anterior part of the abdomen, where the bladder's going to be. Okay, so now we're going to go ahead and do the voiding. Now, this may be done under floral, or sometimes we'll have it done just with a radiograph. So the card's going to say,
ECG, full bladder, voiding, show reflex and prolapse.
Watch out.
so if we're going to show reflex,
People remember this.
if we're going to show reflex, we need to do a stress, like a voiding type, where they're bearing down. If we're showing prolapse, what position do we have to be in?
Upright.
And we usually do voidings upright also because it's a little easier to have the patient urinate upright when they on the table. Okay?
So most of the time
Genesis.
it's PG.
Yeah.
It's upright. I'm going to use your 10%. I'm going to sit down because I don't want to be on my hands and knees on a skirt. Bad enough. You guys filming what you're filming. Okay, I also need the urinal over there. Okay, and I'll just skip it. Get it up white. What? Okay, so in this case, this is an important point. I don't know that I covered this with the series notes, but in a VCUG, typically we use an 11 by 14, not a 10 by 12. And the reason is because we want to see the bladder, but we need to see the urethra and also the reflex. So if you come down too closely, you may not see the reflex in the ureter that's going out. Now this blocker should be down because we don't want to put it in the ureter here. Okay, so I'm going to start by centering him in the AP position. So here's his iliac crest, here's his ASIS. So for a male, I'm going to center 2 to 3 inches below the ASIS or 1 inch above the pubic symphysis. Because for a male, they're going to have a longer urethra, so we want to include that on the image, right? But we also want to see the area in the abdomen where we might see reflex in the ureter. So now the next step is we're going to do a slight oblique about 30 degrees. So turn towards me. And the reason I oblique him is because to see the urethra fully, it's easier to see it if you put the patient in an oblique. So you try to do it straight AP, the urethra is going to be at a tangential, maybe. Okay?
So first we center and then oblique and center.
Yeah, just to get your up and down, it might help to get the centering first. But I'm still staying where the light is in between the ASISs here. It's just I have a little bit more light because I'm using 11-inch now instead of the 10 by 12. Okay, so now I'm going to hand him the urinal. So which hand should he hold the urinal in?
The left.
Because if he uses his right hand, see what happens? You're going to have a hand over the bladder. So you want to have to hold it in his left hand, keep his right hand back. So now I've got everything centered here, my cassette centered. I've got this marked with the left marker here. This is the left side of his body. Okay, so now I'm going to say, all right, I need you to empty your bladder. Go ahead and pee in the urinal.
Can you just turn away?
Actually, what I would do is I would go out of the room. And I'd tell him, when you feel like you have to go, let me know. And so you kind of darken the room, you go out,
Light a candle.
wait. Turn the water on, flush the toilet, wait. So as you can see, it's not the positioning that's the difficulty with this exam, it's the patient care that you have to do, because the patient's going to feel embarrassed. I'm assuming guys have an easier time doing this than women. But still, you know, especially if you had a female tech and a male patient, he might feel a little uncomfortable sitting there, you know, okay, I'm waiting. So you don't like, okay, I'm waiting. You know, you go out of the room and say, all right, let me know. And then when he says, okay, I'm going, it's kind of like they're drinking esophagus. Then you just go ahead and make, okay, hold still and make the exposure. Okay? All right. So what about if we have a female?
Like a little cone one.
No, we can still do it upright. I think women have an easier time trying to urinate upright than they do laying on a table. Either way, it's unnatural. So now, like I showed you, some places they have a female urinal you could use, so you could have them hold on to the urinal as well. For a female, I wouldn't center quite as low. I'd be like 2 inches above the pubic symphysis and halfway between the ASIS and the pubic symphysis, because they're not obviously going to have as much of a urethra. You know, men's urethra is 6, 8 inches, whatever they tell you it is. Women's are going to be like half an inch to an inch.
Would you say at like an inch below ACES? Or at the ACES?
I was 3 inches below before, now I'm only 2 inches below the ASIS.
2 inches below.
So I'm halfway between the ASIS and the pubic symphysis. I'd still use 11 by 14 just because of the reflex. It depends. If this is a small female, they'd use a 10 by 12.
Okay, I just have to tell the people on the first left.
Oh, okay. All right, then let's change it to 10. All right, we changed it to 10 by 12 because we don't have a body urethra to deal with. For a female,
Sorry.
right? For a female?
Yes.
For a female. Okay, so let me have a 10 by 12. Well, if you look at the films I did, actually I did them on
10
April.
by 12.
Should be one right there on the
I was saying we either need to tell the
Yeah.
first
Well, that's now holding it.
But we could
We'll
use
stick
either or.
Let's just keep it at 10 by 12 for females, 11 by 14s for males, okay? So we're consistent in both classes, and that's what the card wrote on the side. Okay. All right, so I want to make sure I'm in between her ASISs here. All right, now I've given her the, giving her the urinal. That may not work, or you may not have a female urinal, so then you have to put towels between your legs. All the girls are like, there's no way, right? And so also think about, you may have to take their shoes, have them take their shoes and socks off, because if they start urinating, it's going to run down their leg, it's going to get on their shoes, it's going to get on their socks. And, all you do is, I know this is uncomfortable, but after they're done, you take them into the restroom, you give them clean towels and washcloths, maybe a gown to change into for the post boys because it doesn't have contrast on it. So it's just, that's what we do. Yes.
So for these two, for the exam for male and female, we don't shield, right?
No,
Okay.
can't shield,
So this
because
is the
we're
only
right,
one.
even with the males, because we're right into the, urethra, so. Any other questions about that? Okay, so this would be, change of pace now. Go back to Dolphin. Oh, yeah. No,
When we take the exposure, is it while they're peeing?
yes. Because you want the urethra filled. If you don't do it while they're actually voiding, iliac crest, and then just below it, so skosh below.
Mobility of the kidney and the bladder.
Because remember, when the patient stands, things tend to drop. They can drop as much as how much? Kidneys.
4 inches.
Well, the book says 2 inches is normal. They can drop a lot below the subject book, but
It's on iliac crest?
2 inches.
right below the iliac crest. Because we want to make sure to include the rami to get all of the bladder.
A
So
gooch
below the
level.
pubic symphysis.
No, 1 inch.
Skosh. That's goosh. Skosh.
A
Skosh.
Skosh. And here's the iliac crest, right?
Skoosh.
Okay. I'm about 1/2 inch below his iliac crest. Okay. Are there any more GU cards that we have to look at? That's it, no? Okay, now I want to switch gears a little bit if you don't have any questions. I want to show you, for next week's lecture, I'm going to lecture on hepatobiliary, which includes tests like ERCPs and T2 cholangiograms. Basically, it's all imaging of the gallbladder area, gallbladder and common bile duct. So I'm going to show you how you would position for those post-contrast or scalp films for the gallbladder. Because you won't have time to practice this next week, your test is next week. But you could get a card that says T2 angiogram scalp film. So I want to show you where we would center for that, okay? It's nothing new. Most of these positions you've done for something else already. Okay, so for this patient's really got a lot of problems.